Hello, everyone. Welcome to our next podcast. Aspirin. What's the deal with aspirin? Millions upon millions of people are on aspirin. Is it the most amazing drug ever, or is it dangerous? We are going to be diving in.
So there has been a lot of talk about aspirin over the years, and I think people have heard quite a bit about this. But when you think about who should be on aspirin, you have to break it down into two categories. So there's primary prevention, and then there's secondary prevention. So what are these things? So primary prevention are people that really don't have any cardiac disease, any heart disease. They don't have stents or any diseases like stroke that they need to be on aspirin for. And the second category is secondary prevention. And those are people that do have these diseases. So somebody that has had a stroke, somebody that does have stents, somebody that has had significant heart disease. And the data behind these two conditions and who should be on aspirin and who shouldn't is actually quite different. Peter, what's your experience with this?
Well, I mean, you just kind of summarized all of my patients with the, secondary prevention. And so I think the bigger picture and probably why we decided to talk about aspirin.
Sorry, Peter, but have you heard of aspirin, or is that?
No. Well, I know how to give it. I know that you probably don't know how to prescribe it. But,
all right.
So I would say this is that we gave aspirin out to everyone. I hate to say it like candy, but everyone who saw a cardiologist can relate that probably got aspirin thrown on board, right? And so over the age of 50 primarily, I mean, if you had like a sibling, brother, parent, great-grandparent on like your mom's removed side or dad's removed side. Yeah, or maybe like you had a pet who had heart disease, you probably ended up on baby aspirin. And so I don't know if that's you guys saw that. I deal with more secondary prevention. So, for all of you who don't know, I'm a cardiologist. So, this is really in my realm. But
Absolutely. And of course, you have that tremendous experience. I mean, primarily we see aspirin prescribed, and questions we get are, should we take aspirin for primary prevention? A little bit of history. I mean, it's been around forever. We're talking about, I think, 1890, so 125 years ago when this drug was first invented. And in my mind, I tend to distinguish between drugs like that, which have been tested, so many people tested might not be the right word, but prescribed for decades and are not making a ton of money now versus a lot of the more shadier big pharma drugs, shall we say. And aspirin has been used for a very long time. I mean, the data, we have to look at a number called number needed to treat when we are thinking about benefits. So that means how many people, this could apply even to an injection. I wish we had talked about this more during the pandemic, but how many people need to be prescribed a drug or an injection to experience a benefit? Do you want to get more into number needed to treat, Ben?
Yeah, so number needed to treat. So it's very different, again, when you're breaking the people down into those two categories. So primary prevention as opposed to secondary prevention. So let's think about primary. So those are, you may have gone to your doctor's office and they said, hey, you have a family history. Maybe we should get you on an aspirin. So that's when these numbers become very important. So you don't have heart disease, you don't have a stroke, and the number needed to treat is quite high. I think it's 200 to 300, correct, patients?
Yeah, 200 to 300.
To reduce the risk of one patient having heart disease for primary prevention. Again, if you don't have disease. Now, those numbers are pretty high, and let's not forget that comes with side effects. And let me talk to you a little bit about what those side effects might be, just one of them in particular. And those with aspirin are predominantly bleeding. So when we talk about bleeding, it would be in your gastrointestinal tract.
Very common, yeah.
And that is not unheard of.
What are some things, Ben, that you would screen for as a primary care before you start with someone on aspirin?
So you'd have to know a few things. So one, I have to know if they're taking other drugs that might increase the risk of bleeding. So that's a blood thinner. Now, it doesn't mean you can't take aspirin, but we got to talk about it. Two is if you're drinking alcohol very regularly, that could be a problem. It can irritate your stomach lining. Three, are you taking things like ibuprofen that can irritate your stomach lining? And the other things we'd want to check is we need to know what your platelets are, right? So aspirin deactivates platelets, and those are used to kind of make clots and things like that in your body to stop bleeding. And the other thing is I'd need to know if you were anemic. Are your red blood cells too low?
Yeah, you don't want to take that extra risk.
Do you want to knock it down more?
Great point. What you said there about so many people now, and this is important because a lot of studies don't actually include people with certain risk factors who are on medicines, but many people I see now are on aspirin, they're on clopidogrel, also known as Plavix, and they're also on another blood thinner, perhaps like apixaban, which is known as Eliquis, rivaroxaban, or even warfarin, because they've got other things. They may have had blood clots before. And that all will increase the risk of bleeding on aspirin.
Yeah, I mean, I think like we run into this, and what you alluded to, Suneel, is this whole like dual antiplatelet therapy. So we talk about aspirin. Some of you out there may have heard about Plavix, and that's really important. I'll speak to a little bit later about people who have either aspirin allergies or use Plavix or clopidogrel as an alternative, or who have coronary stents. But that is a big problem. So this, polypharmacy, which is something that we could do a whole another video podcast on.
We will.
And it's really just about medication interaction. And there are, in my world, I see people on blood thinners. There are blood thinners like aspirin that prevent heart attack, stroke. All right. But then there's other blood thinners like rivaroxaban, apixaban, which is Xarelto, Eliquis, dabigatran, and the older one, which, I hate managing is Coumadin. All right. And you guys maybe don't see that side as much as I do, but
I see a fair amount. I mean, that could be a tough one. Yeah. Now, Peter, we're talking about primary prevention where the numbers aren't particularly good in terms of the number needed to treat to prevent disease. Secondary prevention, the numbers are pretty good. Correct? Or would you agree or not so much?
I mean, we have to be, I'll be clear about it. I mean, so the big push came when, in the past few years that it came out, and really in the mainstream media. And I was inundated as a cardiologist, as you guys were with primary cares, about should I be on aspirin or not? And people stopped aspirin.
Yeah. It's so interesting as well how the mainstream media will go all in on attacking a drug which has been around forever, which is not making a lot of money for many people. Yep. But yet there are other drugs which we'll talk about. Exactly.
It's not big pharma.
It's so funny how the mainstream media does that, because I remember that too, as you alluded to. Everyone was taking themselves off aspirin when actually, I mean, you want to talk about the secondary prevention.
Yeah. So secondary prevention is like, hey, listen, you had a heart attack or a stroke. What can we do to prevent it? And that's probably where people end up seeing me, even though I'd love to see people like before all this stuff happened. And part of me also wonders like why I haven't seen this patient prior to having a heart attack. It's so many risk factors, but that's again a whole other story. So again, secondary prevention is really just focusing on those people who came in with a heart attack or had a significant blockage in the plumbing around the heart. I mean, and those people are put on aspirin, and that is indefinite, all right? And that is
usually
very clear.
If they've got a stent there, you aspirin, just have to prevent clot forming,
And people aren't put in clopidogrel, and the length of duration, generally is a year, but that can be discussed, with your healthcare provider who treats you. But stopping aspirin can cause what we call stent thrombosis or clotting off stent. All right. Also, people with bypass surgery. I have it all the time that people didn't think aspirin was important. I think probably people think about it more as maybe a supplement and maybe don't mention it as much. And that's really important. Like sometimes you don't think of it as a medication.
Because you get it over the counter. And to be honest, I'm somebody who I would far rather people were on no prescriptions, no meds, but there are far worse things you can be on than an aspirin. At least you can get it over the counter.
And I agree, Suneel. And I think I wonder if aspirin was a new medication coming out now, what would the data be, or what what would the outcomes be? Would it actually be approved?
It's a great point. I've heard the same thing said about even Tylenol, acetaminophen, paracetamol in the UK, that if they actually released it now, it would never be approved. But it's been around for so long.
It's been approved. It
definitely wouldn't. Yeah.
As I know, with I see a lot of older patients. Tylenol really probably doesn't work that much for joint pain, but that's another topic to discuss. But aspirin, and we'll make it clear, does help in secondary prevention.
Yeah, it's really important to distinguish between the two. If you're healthy and haven't had anything happen to you, the number needed to treat, I don't particularly like those odds, 1 in every 250. But if you've already had something happen, then the odds shift dramatically to 1 in 40 or so. So again, it's not like stellar by any means. And I will always say that you cannot beat lifestyle if, as in most people who have heart disease, not everyone, but most, the insulin resistance, the inflammation, lifestyle is always going to give you a much better benefit than any drug, whether it's aspirin or anything else. And I'm sure you would agree with that. But having said that, if you've had something really bad happen to you, if you've had a stent or a heart attack, stroke, there's far worse things that you can be on than aspirin. So it's very important to distinguish between the two. I want to move on quickly to colorectal cancer, colon cancer, because many of you may have seen that there were some studies done suggesting that taking aspirin could bring potential benefit for reducing risk.
I'll defer to you, Ben. That's kind of the opposite side of the body that I deal with.
True.
Absolutely. Yeah, that's on the other end, Peter. Yeah, correct. I think when you look at the data surrounding, again, primary prevention for colorectal cancer, you're going to see a similar story played out, that the data really just doesn't support widespread use when you look at the risk-benefit profile for preventing colorectal cancer in patients. So, is it worth the risk of the bleeds and everything else that can come with aspirin? And is the data really there to support a benefit? And, when you go through it, you really just don't see it.
Yes, yeah. And I would think any benefit that's there is probably linked to the fact that it's anti-inflammatory.
Very likely.
Most chronic diseases out there, and even cancer, have inflammation as their mechanism. So it's very plausible that aspirin could provide small benefit. Okay, we're going to wrap this up then, with each of us speaking about our overall summary of aspirin. And remember, this is not medical advice. These are our own thoughts based on data. So what I would say again is distinguish between primary prevention and secondary prevention. There's a difference between a healthy person taking aspirin and somebody who already has had something happen to them, where there's much more benefit potentially of taking aspirin. And I will say again, you cannot beat lifestyle. You cannot trump lifestyle. Can I use that term? You cannot trump lifestyle.
Of course you can.
Exactly. But I'm sure we can use that word. Yeah, exactly. It's a great word. So basically lifestyle, if you have suboptimal tick boxes, whether it's diet, exercise, stress, work on those. That will always bring more for benefit and an anti-inflammatory effect. And the other caveat that I'd like to add, I'm speaking for more than 30 seconds, by the way, but aspirin doesn't have to be all or nothing like any drug. You could take it twice a week or 3 times a week. I have lots of family members who don't want to take it every day because they're concerned about potential risk. And by the way, we're talking about the low dose aspirin, because high dose actually doesn't have more benefits necessarily than low dose. But frequently I've said to them, well, why don't you just take it twice a week or 3 times a week? I mean, it's over the counter. It's not like being on a prescription. So those would be my thoughts.
Yeah. I think, he covered a lot. You covered a lot of what I was going to say. So thank you. You left me with very little. But the one thing I'd say is side effects. So you have to be very careful with what you're taking with aspirin. So if you're on an aspirin, you have to be very careful. Like I said, with alcohol, you have to be careful if you're going to take ibuprofen and things like that for joint pain. If you're on a blood thinner, you have to speak with your doctor about potentially how these are going to work together, and you have to be monitoring that. So that would be my big things when it comes to aspirin.
That's true. I mean, I'll finish up because I am the cardiologist here, and I probably know a lot more than you guys just in general. But
we're gonna debate this after.
Yeah, we'll have another. No, highly unlikely.
Everything here is a risk benefit, and I think that's the most important thing to leave here with most medical, with medications, and actually most procedures and everything in medicine. It comes down to risk benefit. That's something that as patients, people need to learn how to maybe talk to their doctor about the risk benefit. Really quickly, aspirin, we say people wonder why baby aspirin. I mean, the most effective dose of aspirin was 70 milligrams. So as we go up on the dose of aspirin, as well as any other medication, the adverse effects go up. So there's a 3 to 5-fold risk of going from a baby aspirin, which is 81 milligrams in the United States, to an adult strength, 325. So my final verdict on aspirin, aspirin definitely has its role. I definitely support the use of aspirin in secondary prevention. Doctors, healthcare providers don't ever want to be the person to stop aspirin on someone, or sometimes even start it, because they're always worried about the risk of bleeding or the risk of taking off it. So you really have to have that talk, with your with your provider or your doctor, whoever's taking care of you, to really decide what's best for you.
Absolutely. Well said. Okay, everyone. Thank you for watching. We will see you again next time.